I'm not. I'm going.
So you've got any more seats then?
I'm not staying. I'm in Crow and Go.
Oh, right, okay.
But you do still have Nigel and John. So, but you take this.
Possession is 10 tenths of the law here.
Unless you want to do the whole panel. Good morning, everybody, and welcome. Can I encourage people to join the room, find your places, and welcome to day 2 of the Shared Care Record Summit. Hope everybody had a nice time and made some good connections last night, and raring to go for our next sessions. I'm Astrid Fairclough. I've met many of you through the MPD group, National Programme Directors Group, and Lee wanted me to just run through some of the bits and pieces today. We're going to run through, in case anybody wasn't here yesterday, even bigger welcome. There's no fire alarm. Go to the nearest emergency exit if we do hear anything. Toilets are on the ground floor, so where you came back in, and then there's a little sign. But we're going to start now with a panel session, and I'm very pleased to welcome Nigel Wells, who's Clinical Director for Humber North Yorkshire ICB, as well as being Yorkshire and Humber's SRO. Yorkshire and Humber Care Record. Sorry, don't we all call them Yorkshire and Humber, and sometimes forget the Care Record. Sorry, Nigel. So I think the eminent panel that Nigel's going to introduce is going to be looking to some really challenging questions about the future. So if I can just hand over to Nigel, thank you very much.
Thanks, Astrid.
And speak to you all soon.
Thanks very much, Astrid, and wonderful to be here. Just wanted to take a couple of minutes to maybe reflect on what we saw yesterday or heard yesterday about maybe inequity of access and inequity of care. So we might remember that Melissa Mead came to talk to us yesterday around her son William and what the inequity of access was for his care and what the devastating impact that had for him, for the family, but also for the clinicians that were involved with that baby as well. And then I know later on in the day we had Rob come in to talk about systems and how systems being joined up more together could help, and the flows of data and what that means for us as well. And that really is an inequity that's happening about treatment. So probably Rob talked about social determinants of health, deprivation driving poorer outcomes. And I'm a clinician, I'm a GP, I work in Selby in North Yorkshire. And we have a big patch in Humber and North Yorkshire. And there's massive inequity of care and treatment. So the healthy life expectancy of somebody living in Harrogate is over 10 years more than somebody living in Scarborough. And if you went from here and we drove to Scarborough, you would start to see that decline in healthy life expectancy. And as you enter Scarborough, it's like falling off a cliff with regards to healthy life expectancy. And these are all things we know and we've known for many, many years. If you're somebody who understands or sees Michael Marmot's tweets and have seen him talk, these are all things that we know and can get to around social determinants of health and driving healthier populations and outcomes. So it was really, really powerful stuff that we heard yesterday, and hopefully we're going to continue that today. Because the other thing that Rowan said yesterday was harness the energy in the room, harness these things that you hear and drive on, because you are the experts, you can do it for us. And I'm so grateful that you're here to drive this forward for us. When I talk to my patients, they think that everybody knows everything about them. And they can't believe that they don't, but then if they go on holiday into Europe or further afield, they can go to an ATM and get out their money. They just can't understand that we just can't see it. So it's something about how we join it all up. And it's really, really, really important that we do that. So I just want to say again, thank you very much for coming. Thank you for your energy, and thank you for your work and dedication to move this forward for us. What we're going to do today is we've got a panel of experts, so it's great that we're all here today for you, and we've got some questions. And probably what we're going to do is I'm going to ask the panel to introduce themselves. I've got a few questions that we're going to start off with, and we'll see how we get on, because we've only got half an hour, but I'm sure colleagues would be happy to chat to you outside of this, at breaks as well. So I'm going to ask the panel to introduce themselves. So Steve, can I start with you?
Hi everyone, morning. I'm Steve Pugh. I'm Head of Service for Access and Digital at Leicestershire County Council, and I'm also on the board for the Shared Care Record of Leicester, Leicestershire and Rutland.
Hi, I'm Zahran. I'm Chief Technology Officer for YAS. I'm also a member of the board for Yorkshire Humber Care Record.
Hi everyone, I'm Rob Walker. I'm Programme Manager for Health and Emergency Services at Tech UK.
Hello, my name is Astrid and I am an consultant at Channel 3 Consulting, and I lead a lot of the work on shared care records. I'm also a clinician by background, although I don't practice anymore.
Thank you. Yes, it's James Reid. I've got a few hats. I'm a consultant forensic psychiatrist in the NHS, work on the Birmingham Solihull shared care record, among other things. And I'm also a physician executive at InSystems part-time.
Brilliant, thank you. So our first question that we got in was about where do you think shared care records will have the biggest impact in the next 12 months? And so I was going to start with Ola on this, and then maybe go to Steve as well to talk about it.
Okay, I think we had a very good opportunity as Yorkshire Ambulance Service to be the first trust to work with on the project itself. Our biggest problem is how we're going to signpost the patient to the right pathways, and it's always difficult to know, especially that when paramedics attend at scene and they haven't got a clue about the patient, there's no information, and we have been working with the region and how we're going to do quite a lot of work to make sure that we can actually help our paramedics, and not just paramedics, 999 and 111 service as well, because we are a regional provider. We provide service for 999, 111 and patient transport system. We've been working with them now with quite a lot of initiative work, and some of them, it's like how we're going to get alert to say that I've got mental health patients. So our EPR now records saying that to our clinicians, when they're at scene, they get the NHS number, they press on that, they're actually saying that, flagging that there's end-of-life patient. It's happening in the North and Humber area only. It's not happening in the whole Yorkshire, but it's a really good piece of work to say that we can actually shout about it. We need to extend this across the whole region, and this is what we're doing now. The other piece of work which is actually helping us really massively is about sharing our records, 999, 111, and patient transport record to the region. Because GPs, they don't know what happened to the patient, had been to the hospital before, or has been the rang 111 or 999 service. And so by sharing this our information, we actually inform all the clinicians across the region, as well as will allow us, our clinicians also have access to the shared care record across the region. We never had that before. That's absolutely fantastic piece of work for them. The other thing as well, which is really quite important in terms of improving the handover time across the hospital, it's the biggest problem for all the ambulances and hospitals. We have been working on the transfer of care, which is actually electronically transfer our record from our EPR system into the hospital on route, which actually gave them an early warning about the patient condition, like observation used to, and all the information related to the patient. When we signpost them to the hospital will be able to see that patient actually in the queue outside. They can go and grab that patient as fast track. So that's quite a lot of work in the background with Yorkshire and Humber, and actually a very good opportunity now for us to move and actually enhance what we do across the region. Yeah.
Brilliant, thank you. Steve?
I'm only standing up because this thing's in the way. So. Well, first of all, my background's IT, so for me, there's a technical benefit, which is we're not asking suppliers and giving them lots of money to develop bespoke APIs all the time, which was the old model. And having worked with health and social care for about 10 years now, trying to get that conversation with different suppliers to open up their systems, even though they said, of course it's open and we'll develop APIs for you, just hasn't happened at the pace that we wanted, no matter how much money we want to throw at them. So having this shared care record has been a revelation. And our programme team in Leicester, Leicestershire and Rutland have been brilliant. And so another benefit for us is about actually working together from a local authority perspective with health colleagues. And I think looking ahead, we're already seeing benefits from Rutland. They're connected to the LLR care record. We're in the process of being connected. We can see that our staff, or their staff, aren't making as many telephone calls. Can you imagine the amount of telephone calls that go on around the organisations? People playing telephone tag for hours and hours every week, whether that be someone, a social care worker, trying to ring and get in touch with someone on the ward about someone's discharge or someone's condition or someone's medication. That time saving is just, well, it'll be something that probably goes under the radar a little bit, and we never understand the amount of benefit that it gives to us, both, as I say, for social care workers and for health workers. You know, the amount of telephone tag that goes on in the system must be tremendous. And then you've got the benefits, obviously, for the person who's in receipt of care. You mentioned, and we have the same issue, you know, can't you see our record? Why are you asking us for that same information time and time again? And that will be a massive benefit to someone's care at the end of the day. And that's what this is about. It's about being able to have that access to an episode of social care, or have access to information that's on System 1 or in a patient admin system, and be able to quickly see and know what's going on with that person and understand what's going on with that person. And we're linking up in Leicestershire and Rutland quite a lot of different organisations. We've got Loros, which is an end-of-life charity, and I know some informal feedback has been for them not having to make loads of telephone calls. I know it sounds just trite really, but it is an important factor, the amount of time that people are spacing, just chasing, trying to find information for someone's care, and that'll be the big benefit.
Brilliant, thank you. I don't know whether anybody else wants to comment on that from there.
Well, the trite answer is where it's going to have the biggest impact would be Birmingham and Solihull, obviously. But I think more broadly, I think social care is, I mean, everyone talks about social care, but I think that is a big area of growth. And I think, as we were having conversations yesterday, I think we've underestimated the level of interest and willingness among the social care community to be involved in this work, actually. Certainly we've found an open door, actually. There was no resistance. I mean, I think we're quite used, perhaps, to having bits and pieces of resistance and reluctance in the health space, but actually in the social care space, we've encountered no resistance at all, and similarly in the third sector. So I think those areas are where there is the most potential for growth and impact, actually. Brilliant,
thank you. Okay, we're going to go on to our second question, just conscious of time. Now, we got this question in, and we've actually planted the answer in the audience, so I'm going to come to John for this. How will the Digital Health Laws and Regulation United Kingdom 2023 change the adoption of standards and information sharing? And John, I don't know whether you want to come up on...
Glad you know the answer.
I've got the answer here.
So this was a slightly planted question, as you can see. It was because yesterday in our data standards session, we were talking about some of the challenges around the enforcement of data standards. And I was conscious that there is some things happening which people may not be entirely aware of. There'll be somebody in the room here who knows chapter and verse, I know, on the DCMS Data Protection and Digital Information Bill. Now, Clause 99, I won't ask if anyone would like to read out Clause 99. It talks about information sharing in health and social care. And it refers to a thing called Schedule 12, which amends Part 9 of the Health and Social Care Act 2012. What's important about this is that there are three key things in there. It gives the Secretary of State power to publish standards, well, we've kind of got that, but also the power to create an accreditation scheme against those standards. And then the killer one is the power to require IT suppliers to comply with those standards, and a related power to publicly censure them if they fail to comply. So we've sort of changed a bit of the balance here. So if you're a supplier and you're not complying with those standards, then you might find there's a public censure. And this is quite a powerful tool. Now, it's going through Parliament at the moment, so it may not get through, but certainly that's the wording there. And if you read underneath, it says the aim of the clause is to encourage the adoption of open data architecture standards. So that's why it's in there, and that's the power that they should be able to exercise. And I think that has quite a big implication for us and, well, the supplier community and also those of us working in health and social care.
Thanks, John, for that good information. I don't know whether anybody from the panel wants to add anything to that. Yeah.
Sorry, I'm obviously representing suppliers, so I'll come back on that if that's okay. I think the fact that it is being mandated is very good for everyone. It sort of sets out the standards and the must-haves rather than the nice-to-haves, if you will, and everyone will therefore understand what needs to be done. I think the main issue would be is the regulation and the enforcement of it, but also creating support for it. The standards will require sort of data mapping, and every field in the standard must therefore be data mapped to a sort of data item in source of your systems that feed the SCR. So I think ICS is, whilst it's good that it is being mandated, need to understand how their systems actually work and what they have and how their data maps to that said system, and not expect that all to fall on the supplier. I think it cuts both ways, it works both ways. And I think something that I found out yesterday that I thought was particularly interesting, that not every data item is being consistently used across the country. I think that is imperative that happens as well. But the suppliers cannot be sort of expected to take that on, but they can and will advise on that. So, yeah, sorry, did you want to?
Yeah, I've got sort of two views. Obviously, it's a good thing if these standards are going to be enforced and enforceable. That's obviously a good thing for everybody, and it's good for suppliers actually, not least because I think most suppliers, in my experience, are keen to do the work. It's not an unwilling. Some, and with my customer's hat on, we've encountered some who aren't, and I think it's right that those who are sort of refusing to be engaged should be called out. It remains to be seen, I suppose, whether those powers are actually used. Because I think there are powers that are available now, particularly with things like clinical safety, that could be used that aren't, in my experience. So giving the Secretary of State or whatever his powers is one thing, and the second question is whether he or she is actually going to exercise them.
Yeah, really good points. Thank you very much. Okay, our third question is, how do we improve the NHS's ability to work with system suppliers to improve the usability of systems? And I think, Rob, you were going to start us off with that, if that was okay.
Yeah, absolutely. I think the big one that comes up from sort of our members quite a lot is that ICSs need to sort out the data sharing agreements promptly between different stakeholders. And so I'm told that the biggest impact to go lives is if the trust can actually set up that DSA with stakeholder organisations. And not forgetting the social care aspect of this as well. Obviously, they can only see a particular aspect of an SCR. So I think it comes back to the 5-letter word that is trust, and it's needed for genuine collaboration across the health and social care sector. And I think it's fantastic that Steve, with your experience of ICBs, I think ICBs can lead on this and be that sort of organising force. What I would say is something we spoke about yesterday as well was the need to engage clinicians early and throughout the process as well. I think the most successful SCRs are clinically driven, and making sure that the data collected is actually used and is useful as well. So I think strong clinician engagement is particularly important. And not to take up all the time, but just to say one more thing about suppliers do rely on good references. Customers are the biggest advocates for those references. Suppliers should have done this before. I understand that SCRs are being implemented as they go, but they can be a trusted advisor, so please do use them. What they say can help, and you can advocate for them, so they will want to do a good job, as James mentioned as well.
So I think I have a practical one. It's one thing that I have seen in terms of usability is that although you might have access to the data, you don't have all of the data in the same place. And an example of that is the data that flows from GP Connect, which is an HTML file that doesn't necessarily fit in with the rest of the data. And what I hear is if you're somebody who's looking at the patient's or the person's allergies, for example, in your shared care record, you have to navigate to 2 different places to get a whole picture. So I would probably start from that point. If the GP record is something that everybody wants to see, it's just kind of like that source of truth. And so if we make that easier, no doubt people are going to use it more. And I know that lots of doctors talk about the number of clicks, but that's actually how we should measure usability. The less clicks, the better.
Okay, I mean, I think the points about usability, there's an awful lot we need to do about, if you like, intelligently designing what we see. I mean, a lot of these projects begin by obviously collecting together all the data and putting it on the screen, which is obviously fine. That's where you have to begin. But I think the temptation sometimes, I think that's the end of the job. And I think what we're finding certainly is that you probably need, well, you certainly need to curate the data sets you've got to make them more usable. It's likely that a lot of our shared care records already have lots of data in them that no one actually wants or needs. And so we have to be bold enough to start removing stuff as well as including it. And actually thinking about, this is what a discussion yesterday about standards, what the sort of thing that people in sort of settings needs to see. I mean, we could probably agree on the sort of thing an emergency department doctor needs to see, or the sort of thing that you need in some kind of outpatient clinic, in general terms anyway. And I don't think anyone's done that work yet. And if we can start to do that, then I think we can do better at creating, you know, a usable thing that's more or less to some extent consistent across all the different schemes and products.
Great. Well, I don't know whether there's anything from your point about usability of what you've learned of the last 12 months or so.
I suppose yeah, I think we've been using obviously quite a lot of standards in the last couple of years anyway. We work with Yorkshire Hamburg quite a lot of time and with the subject matter expert on our end, subject matter expert on our end. The governance we use is quite really rigid, and I think we go through a really robust process, including the clinical safety process as well. I think one of the things I will say that I want to say this, I know that's maybe outside of what I'm supposed to say, but I think having outage with Astrid about the security make us really feel about we have to take it extremely serious. And I'm talking about suppliers now. So suppliers working with us as well as ourselves as well. We have to really tighten all the process all the way through. We have lost quite maybe 6 months of work for 111 when we lost it. But to do this one now in terms of standard, yes, we have to follow standard. We need to make sure, not just following the standard, make sure all the process behind this is actually really very tight and also being tested and going through a very rigid process. I think this is really quite important for us, and it's useful for suppliers to say we can do it, but how can we trust that process? And I think that's really big risk for us, yeah.
Great, thank you. Stephen, from you?
I think it's just going back to the IG point, really, which is, you know, there's quite. We've worked hard in Leicestershire, Leicester and Rutland to get the IG. We've got for IG people, proactive IG people. You know, they're not quite the computer says no people anymore. And I think if you try and explain to them what it is you're trying to achieve, I think it does try and it does unlock things, and they are willing. And if you come across people who aren't, get in touch with us, and we'll try and help you through that maze.
Great, thank you. I think Astrid, the number of clicks is absolutely right from a clinician's point of view, and that's me being open and honest. I know that really does make an impact. Okay, our last question, and then we can, hopefully if we've got time, we can open it up if anybody's got any points that they want to clarify. And this, I think, came out of Rob's talk yesterday about how essential these things are going forward. And so my question is, are shared care records and data essential as oxygen to the NHS? And what I'm going to ask the panel is also, what do you think the blocks are that we need to overcome in the next 12 months? If we agree with that, what do we need to push on? What do we need to lobby? How do we push through it? So if that's all right, Steve, because you're right next to me, I'm going to start with you, if that's all right.
It's a difficult one because without oxygen, I think we'd all be on the floor. But certainly, I mean, you can see that it's an absolute priority for us to be able to share that information and have access to that information, because for too long we know that it's been hidden away in silos. It's difficult to get to. It means an absolute industry, certainly from our perspective, for instance, our experience of trying to get access to Health System 1 modules has been traumatic at times over the years. It's a lot better now, I'll say. But it's still that process, and you still then have to set up service level agreements and all those sorts of things, and say all the information governance and train the staff and everything else. If you can just move that out of the way by, for instance, giving our social care workers, you're looking at this particular case for Mrs. Miggins. We always use Mrs. Miggins, I don't know why. You press the button on her record and it says, okay, here's access to her health data. You don't need to log into another system. You don't need to be trained in that particular system. You just need to know where to look for some of the information. So it's a much easier access for that social care worker, so they can quickly get the information and deal with that person's care. So I think, yes, I do agree with the statement in terms of, obviously, because we wouldn't be here if we probably didn't agree with the statement. And, you know, we can start already seeing, as I said to you before, we can start seeing the benefits that this is already delivering for us. But there's an awful long way for us to go in terms of overcoming some of the technicalities that we've still got in the system, how we look at, I think you mentioned, you know, there's so much data out there, looking at the data and what is giving the most benefit and trying to put that front and centre. And then obviously we've got the bit about encouraging the public to actually come on that journey with us. We've got a little animation in Leicestershire and trying to encourage people to not opt out really from that and sell them the benefits. So there's still that road ahead as well to sell the benefits of the system to the public.
I'm just going to go back again to signpost the patient first time. That's what we need to do. Our clinicians can go to patients at scene and take them to the hospital and say they stay in the hospital for 6 hours and they're not the right place for them, they take them somewhere else. And we know that this journey is happening all the way through. I think having access to shared care record will actually provide information to the clinician, whether that's taking calls like 1999 or 111, or our paramedics at scene, to be able to divert the patient to the right pathways first time, whether that GP or hospital. We need to really reduce the admission to the hospital. We need to make sure if you go to the hospital, it has to be a critical case to go there. We know the crisis is happening now, and our clinicians are crying out for having access to a patient record. This is what we need to do. It's crucial for us, because we are the front line of active to any care system. If we can reduce that from that level, I'm sure that will actually cascade that all the way through. The other thing is, as well, is we are short of staff. We are short of staff by 30%. So that's not going to go away. So we have to compensate that by technology, doing something at the point of care to allow them to do something intelligent. Referrer, like electronic referrer to GP. Why cannot paramedics do that? They're not allowed to do that as we speak now. We need to encourage that work with the national team about. We need to be going through the referrer. We need to use the new technology, which is like the BARS standard. And I know, John, we're talking about this now. It's how we're going to actually start doing this piece of work. How we're going to leverage this we're working now across the whole UK about sharing 999 calls across the whole UK. This is something new, came to light, and we're going live in November. So all of us now taking calls from each other, and we're passing these calls electronically. Amazing, that piece of work. During December time, we lost patients because we didn't have capacity in the system. But now, by using this system now, we can take calls from anywhere else and pass that back to the original trust. Which is, yes, it is crucial for us. Without this, I think we're not going to be sustain the business. Yeah.
Thank you.
Yeah, I think data is absolutely key to the future of the NHS and preventative healthcare. I agree that prevention is better, is the best form of treatment. And I think digital transformation has gone from a nice to have and something like is added on at the end of a project to an absolute essential, and is really needed to sort of help sort of drive down some of the issues that we're seeing across the NHS just now. I think in terms of blockers, I'm hearing a lot from sort of CIOs and CDIOs. It's legacy systems. James Hawkins, the CDIO of Yorkshire and Scarborough NHS Trust, came and did a presentation to Tech UK members, and he showed us this presentation at which he sort of had a digital amnesty, and one of the GP practices handed in a television from the 90s as part of their sort of legacy applications, and I think that sort of says it all in terms of legacy systems. But I think there's also a cultural aspect to this as well. As I said, there needs to be buy-in from clinicians, but there also needs to be a well thought through change management program to sort of any digital transformation project, particularly one as sort of convoluted and complicated as SCRs.
So yeah, I agree 100%. I think data is the oxygen and the shared record is the conduit of that oxygen, for sure. Focusing on the challenges on the next 12 months, I think one of the biggest challenges is going to be to navigate uncertainty. So at the moment, and what I've been hearing from yesterday and today, is that there isn't really a lot of a common understanding of where we're going with the shared record, and I know that lots of us were very encouraged yesterday by the fact that there's going to be a strategy on how to share information at a national level, but that's going to take some time to come. So what do we do in the meantime? And we are in an economic climate at the moment where funding is not really available. NHS is going through restructuring, so they're not able to support us as they would want to at this point. So there's all of that to navigate, and that's going to continue to be there in the next 12 months. And I think one of the things that I've been thinking about as to how to get over that challenge is, so I had a friend visiting last weekend, and I went to the shop, and I bought all the food, all the drinks, got home, I was in a rush, and when you look at all your bags and you're like, I probably should do 2 trips, I'm going to do 1. I'm going to grab all of my bags and just, take them the 2 meters between my car and my front door. And in doing that, I dropped a bottle of wine and it smashed on the floor. And so I had to bring everything in, go back to the shop, get another bottle of wine. And I feel like that's what is happening at the moment in the NHS, and particularly with the shared record, because the benefits are all over the place, but there isn't a lot of focus on how we can actually maximize the value of what we've got. And so I think focus is key. And also helping understand how the shared record is a key enabler of some of the priorities that we have nationally. So we saw some great examples yesterday on how to manage a waiting list, but also thinking about our ambulance colleagues, how we can help them. So yeah, I think that's where I would go at the moment in the next 12 months.
Yeah, I suppose I'm just thinking about this. I think it's clearly obvious we all think it's important. Although I have to say we don't use a huge amount of oxygen in mental health trusts, and most community patients don't use oxygen either. So there's a bit of a broader thing about what's important. If we're going to get value out, I think it's not. It's a bit like the lesson we've learned with electronic records in hospitals. If you went back 10, 15 years, everyone said, well, hospitals need to have electronic records because what the staff on the ground need is information about the patients, which is absolutely true. But of course, a lot of us are struggling in big hospitals with vast amounts of data. And it's the same with shared care records. And what we'll need to do is find new ways of interpreting all that. It's about turning, it's a cliche about turning data into information, but we're going to need all this high tech that's out there to do that. I was thinking about the sepsis case we saw yesterday, and I was thinking about our shared care record at the moment, and I think it might still be difficult, even with a shared care record, to actually put all the pieces together. And I think we'll need the technology to help us do that, to start looking prospectively for patterns, for analysing if we're going to really get the benefit out. Otherwise, we run the risk of just having loads more data and the same staff on the ground trying to make sense of it all, which I think is going to prove quite difficult.
Brilliant. Thank you very much. Now, I think we have to finish in a few minutes' time. It's 10:40, so we've only got a couple of minutes. So I don't know whether there's any burning questions or comments from the floor that anybody wanted to say before we move on. I'm sure colleagues here will be happy to chat with you in any of the breaks as well. I suppose what I've learned from this is that absolutely data digital technology is an enabler, is a facilitator. However, there's a lot that we need to get right about clinical culture and buy-in and actually usability in what we're doing for our patients. And so that's something that is key for my role as medical director of the Integrated Care Board. Although we don't call it a medical director in our Integrated Care Board, we call it clinical and care professional, because the future is not medical. The future is clinical, care professional, and professional, I call it when I'm talking to my colleagues. Because one of the things that you find with the shared care record is the things that you didn't know. Who's involved with the care of that resident or that patient, how it links to you, what they've done, and how you can learn from that going forward. So it's really, really, for me, it's important that integrated care boards, integrated care systems start to connect the system to more of itself, for clinician care professionals and professionals to understand their roles and what they can put to benefits of our patients and residents. And if we do that, then I think we do have a brighter future. But if we don't, then we'll go back into silos and we'll be smashing the bottles like Astrid did last weekend, unfortunately for you. So I think we're almost there. So thank you very much. I just want you to give a round of applause for our panel, if that's okay. And I think now we're going to move into our workshop groups, if that's right, and probably the same as it was yesterday. So it's your A's and B's, and have a great day. Thank you very much.
Thank you.
Thanks very much.